I welcome all the viewers all over the country. We have two experts from Metro Noida Hospital. I am Professor A.K. Agarwal from the School of Health Sciences. To my immediate left is Dr. Biplab Jamatia, who is also the second program coordinator for the PGDCC program. And then on our extreme left, we have Professor Mrs. Ramesh Arora, is the senior cardiologist, head of the, she is the former director and professor, GB Pant Hospital, head of the cardiology, and now she is working as the director cardiology in the Metro Hospital and Heart Institute at Noida. And to my immediate right is Dr. Sardana, and Dr. Rajneesh Sardana is also the cardiologist, senior cardiologist from the same institution, that is the Metro Heart Institute, Noida. And Dr. Rajneesh Sardana is a graduate and postgraduate from Maulana Azad Medical College, and then he worked in the internal medicine and cardiology till 1994, and he did his DM cardiology from the prestigious PGI Chandigarh. So with this, friends, we will move on now, requesting Professor Mrs. Ramesh Arora to tell us about the to tell you about the history taking and physical examination of a cardiac case. Professor Arora.
You all know that with the improvement in technology, non-invasive imaging for heart disease is very common, and most of the centers and most of the cities, even towns, they have with them echocardiography, and this gives us anatomic and physiological diagnosis, but all this is meant to supplement and not to supplant the physical examination. I'll say that the history should be taken by the consultant himself and not by the assistant or the nurse, as it happens at times, because the interpretation of the symptoms is the most important. Once one goes aside or loses the track, then the illness is not taken into account properly, and that really affects the patient care. There are various methods of taking the history, and the methods can be chronological, which tells us about the diagnostic advantage of natural course of disease. They are descriptive, then you have to know about the clarification of character and severity of symptoms. Then associative, relationship of symptoms to underlying disease, the past events, and response to therapeutics, if any. Differential, inquiring about the family history, the risk factors, occupation, diet, exercise, tobacco taking, and alcohol. What can be the source of information? The source of information is the patient himself, spouse, parents for the children, records of previous treatment, and observation of referral physicians should not be ignored, and at times friends for the youngsters. Once you have these things in hand, then how the history is filed? History is filed with reference to complaints in chronological order, history of present illness, history of past illness, history of family history, and mother's health is very important for the small children where you have congenital heart disease, then personal and dietary habits. Once we have the history, what do we have with us? We have with us the primary problem, differential diagnosis, anatomical abnormalities, physiological abnormalities, the status of the cardiovascular system, the past and the current therapy, prognosis, and unanswered questions, which means we have to go from the history to physical examination and investigations. Looking at the cardinal symptoms for a cardiac disorder, one is dyspnea, that is difficulty in breathing, chest pain or discomfort, syncope or giddiness, palpitations, edema of feet, cough, hemoptysis, excessive fatigue. Looking at each one of them, Now, dyspnea or difficulty in breathing. There are many causes, but we have to really concentrate on the cardiac points, and they are that if a patient has left ventricular failure, there is really progression of symptoms from exertional dyspnea to orthopnea to paroxysmal nocturnal dyspnea, dyspnea at rest to acute pulmonary edema. Taking each one of them, exertional dyspnea, one has to really ask the patient and has to note down if there has been any change in the exertion which has brought this dyspnea, because dyspnea can occur even in normal individuals. Once that is decided, then one has to grade it according to the New York Heart Association, whether it is on ordinary activity or whether it is less than ordinary activity. Next symptom is orthopnea. This simply means dyspnea on lying down, and most of the time patient sits up or raises the head on the pillow. This is relieved immediately and not noted by the many patients because they feel that they are just uncomfortable, and if they raise the pillow they are comfortable, so this is missed by them. So you have to here also note if there has been any change in the number of pillows. Going on to paroxysmal nocturnal dyspnea, this is very frightening. When the patient wakes up in the middle of the night, usually 2 to 5 hours after the sleep, they sit up, they have anxiety, they have suffocation, they gasp for breath, and most of the time they even open the windows to get some oxygen. This is not relieved like orthopnea on sitting up. This really lasts for more than 30 minutes, and many times they have to take some medicines before it is relieved. One has to really ask whether the dyspnea occurred first because it is followed by cough. If cough occurs first and the dyspnea later on, then it is because of the pulmonary disease and not because of the cardiac disease. Going on to the next one, that is dyspnea at rest. If we go on to the New York Heart Association, it means that patient is not able to carry out any activity and is breathless at rest. Lastly, acute pulmonary edema, which is a severe form of nocturnal dyspnea, and this is not relieved even after half an hour. Patient gets cough and frothy expectoration, and most of the time they have to be hospitalized for that. The next symptom is a chest pain or discomfort. There are many causes of chest pain, you all know, but to really label as a cardiac chest pain, one has to see the location. Typically it is retrosternal, and retrosternal also mostly in the upper half, rarely right or left side of the chest. Many times it is described as a band across the chest, or sometimes patient keeps a fist in front of the chest, and that is called a Levine sign, and this is really one of the characteristic feature of the chest pain. Radiation is to the shoulder, left arm, mostly to the inner aspect, that is the ulnar aspect, up to the little finger, neck, jaw, teeth, or sometimes to the right side as well. Character: it is an unpleasant feeling which is described as pressing, squeezing, strangling, constricting, bursting, or burning, or there can be many other adjectives to that, but many of them, most of the time, for a cardiac pain, these are the adjectives which are appropriate. Duration: if it's an inguinal pain, it really lasts less than 10 minutes. If any pain lasts less than 20 seconds, it is not a cardiac pain. When it lasts for more than 30 minutes, we label it as acute coronary syndrome. What brings out this pain can be exertion, especially after meal, cold, stress, or excitement. Relief is by rest or by nitrates. Sometimes non-cardiac pain can also be relieved by nitrates because they are generalized vasodilators. If pain is relieved by bending forward, it is most of the time pericarditis. If it is relieved by holding the breath, it is because of pleurisy. An association of this pain, it can be nausea, vomiting, sweating when it is a prolonged one, most of the time with myocardial infarction. Pain in the back, nearly in the scapular region, is also to be taken care of. Many times the pain is that and the ECG is normal. Then we always ignore, but it can be because of dissection of aorta or aortic aneurysm. Going on to the next symptom, that can be syncope. Syncope is always to be distinguished from the epilepsy, orthostatic hypotension, hypoglycemia, hyperventilation, and vasopressor syncope. Cardiac syncope or typically Stokes-Adam attacks are usually rapid onset, independent of body position, without any aura, not associated with any convulsions, urinary incontinence, or other confusional states afterwards. Consciousness is regained promptly, not like epilepsy, which is gradual, and after the attack the face is flushed. If the face is pale, think of vasopressor syncope. Sometimes the syncope is on exertion. Then think of underlying causes like aortic stenosis, IHSS, pulmonary stenosis, pulmonary artery hypertension. Family history of syncope is very important, which gives us a clue to IHSS or QT prolongation syndromes. Edema. Edema of feet is the most important thing which is described by many patients, but for a cardiac edema, symmetrical and ascending is very important. That is starting from the feet to the legs, thigh, abdomen, and generalized. Generalized anasarca can also occur apart from CHF in nephrotic syndrome and hepatic cirrhosis. When edema is around the eyes and face, we first think of nephrotic syndrome, hyperproteinemia, or mixed edema, rather than a cardiac edema. Upper half, if there is edema with slight cyanotic tinge of the face, neck, and arms, think of superior vena cava obstruction. If only one extremity is involved, it's venous thrombosis of that leg. And if ascites precedes edema of feet, which is a history most of the time given when there is a case of constrictive pericarditis. Other symptoms like cough. Cough can be dry, irritating, spasmodic, nocturnal, especially on lying down. Think of mitral stenosis because left atrial hypertension is the one which is responsible for this type of a cough. Sometimes it is associated with hoarseness, that is called Ortner syndrome. Hemoptysis, which can be streak, or it can be a real bout because of pulmonary apoplexy. Think of mitral stenosis, pulmonary infarcts, rupture of aortic aneurysm, tetralogy of Fallot, and Eisenmenger situations. Fatigue, which is mostly ignored in the history, but mind you, patients of mitral regurgitation, rather than dyspnea, they first complain of easy fatigability, whereas mitral stenosis, it is more of dyspnea. Then it can be because of the drugs which we have been giving, diuretics inducing hypokalemia, use of beta blockers or calcium channel blockers, and sometimes fatigue precedes acute myocardial infarction. Dysphagia, there is nothing to do with the esophagus as such, but enlarged left atrium can press upon the esophagus in mitral stenosis and cause dysphagia. Or in a small child, think of aortic arch anomalies. Sweating and spells, you all know, is a feature of cyanotic heart disease, and the first thing what comes to the mind is tetralogy of Fallot. Recurrent bleeding from the nose, mouth, lips, think of Osler-Weber-Randall disease. Apart from these symptoms, one has to know if there is a valvular heart disease, if there has been a past history of rheumatic fever, in which one has to ask for fever, sore throat followed by polyarthritis. One has to be very careful about asking the history of polyarthritis, which involves the knee joint most of the time, but it can also involve the other joints, knee, ankle, brachial, elbow, and so on. This type of arthritis is fleeting in onset. It doesn't leave any residua. And apart from the polyarthritis, one can ask about involuntary, semi-purposive, non-repetitive movements suggestive of chorea. Then the drugs like alcohol, it can cause cardiomyopathy. There will be nothing else. Is the history of dyspnea and orthopnea you are really trying to find out, and the patient is alcoholic. Then tricyclic antidepressants, they can cause arrhythmias, hypotension. Lithium is known to cause arrhythmias. Cocaine, very carefully, you must know that it causes coronary spasm. It can cause acute MI, any type of myocardial ischemia. Adriamycin, which is given as an anti-tumor treatment, LVF, myocarditis, and pericarditis. Radiation therapy, acute and chronic pericarditis. Apart from that, it can cause fibrosis, and coronary artery disease is known to occur. When we have taken all this history and we have taken all these symptoms, then we have to really in our mind find out which NYHA class we are dealing with. Is it class 1, class 2, 3 or 4? And all of us must know about these classes. And to recapitulate here, class 1, there is no limitation. Ordinary activity does not cause undue fatigue, dyspnea or palpitations or angina. Class 2, slight limitation where ordinary physical activity results in fatigue, dyspnea, palpitations or angina. Class 3, marked limitation, less than ordinary activity results in fatigue, dyspnea, palpitations or angina. And class 4 is marked limitation where there is inability to carry on any physical activity without discomfort, and symptoms of angina, they occur at rest. Apart from this New York Heart Association classification, there is Canadian classification for angina, which you can all read in your books. Going on to the physical examination. Once we are asking the history, we are really talking to the patient on our own, and then we are at the same time noting whether the patient is dyspneic, whether the patient is orthopneic, what is the respiratory rate of the patient, what is the color of the skin, is it blue, or the patient malnourished, or patient is obese. These are really noted by the physician when they ask the history by themselves. Then, right from the face up to the toes, we have to see. These are some examples which we are giving, but there are a number of things which can be noted. On the face, frontal bossing, which is present in Down syndrome, epicanthus, protruding tongue, low set ears in Noonas, hypertellurism, Marfan's, dental deformities, malar flush, cyanotic lips, bobbing of head in a case of aortic regurgitation, facial edema. Eyes, exophthalmos, which tells us that patient has thyrotoxicosis or not, but beautiful large eyes, they suggest pulmonic stenosis, congenital valvular pulmonary stenosis. Ptosis, arcus, especially in young individuals for premature atherosclerosis. Xanthilesma, blue sclera, which is a feature of osteogenesis imperfecta. Argyll-Robertson pupil, syphilis, of course, not very common now. When we were residents, it was really common. Then clouded cornea, cataract for rubella, petechiae, very important, which you have to see for infective endocarditis. Skin and mucosa for peripheral, central and differential cyanosis. Sometimes in small neonates, when it is a cold environment and it's very difficult to know whether this blueness which is being seen is because of cyanosis or is it just because of the environment. Then you have to dip the extremities in the warm water and examine the patient. If they become warm, then they are really not suffering from any cyanotic condition. Central cyanosis, there also, if it is pulmonary or if it is really cardiac. Cardiac are mainly because of the intracardiac or extracardiac right to left shunts. To give you examples like tetralogy of Fallot or Eisenmenger syndromes, there you have to give 100% oxygen and see, and the color never improves if it is a cardiac cyanosis. Differential cyanosis, it can be differential both ways. The toes may be blue or the fingernails may be blue. If the toes are blue and the fingernails are not, think of patent ductus arteriosus as a reversal right to left, that is a Eisenmenger syndrome. Or if the fingernails are blue and the toes are not, think in the small child cyanotic condition of transposition of great arteries with PDA with a reversal shunt. In the skin, we have to look for xanthomas, subcutaneous nodules. Subcutaneous nodules are seen really in acute rheumatic fever on the extensor surfaces, or make the patient sit and watch along the vertebral border. The presence of subcutaneous nodules really suggests that patient has carditis. Then in the extremities, polydactyly, arachnodactyly in Marfan's, fingerized thumb, which is a feature of Hall-Torum, may be associated with atrial septal defect, hyperextensible joints, simian palm crease, which is feature of Down syndrome, and lastly, clubbing. Clubbing may be in a cyanotic condition or in a pulmonary suppurative condition. The cardiac problems of peripheral pulses. I have seen everybody going, and I'll first show you the next one, where can you see how the pulse is being examined? That is really not the way one should do it. Right radial, palpate with the right hand, and first 3 fingers are used. Most of the time people use only one finger, and find out the frequency, regularity, amplitude, volume, thickness of arterial wall, and synchronicity. Pulses are to be examined on both the sides, right from the carotid down up to supraclavicular region, coming on to the brachials, radial, femoral, popliteal, dorsalis pedis, and posterior tibia. We have to see the timing, and we have to see the intensity, and look for a brachiofemoral delay, because this will help us to find out if there is any peripheral vascular disease like aortoarteritis, which is not given any of the books because it occurs in the tropics, and coarctation of aorta. With this pulse, we have to sometimes define at the same time what is the type of pulse we are dealing with. Is it a small volume pulse, which is a feature in mitral stenosis, or pulses et tardus is a term described, which means a small volume pulse which has a slow upstroke, and that can be found out by examining the carotid, aortic stenosis, water-hammer pulse, feature of aortic regurgitation, bispherians, aortic stenosis with aortic regurgitation or IHSS, and pulses paradoxis, a feature of constrictive pericarditis. This is just to show you that this is not the way to examine a radial pulse, and this is to show you how the brachial and the carotids are being examined. Carotid is always examined with the thumb, and use a proper thumb. See, for the right one, the left thumb is being used, and for the left, right thumb is being used. Never do it simultaneously together, because you may produce syncope for that. Then, blood pressure. We all examine the patients and we take blood pressure, but we have never noticed what type of blood pressure cuff we are using. The adult cuff which is available to all of us is 5 inches wide, and the bag is about 10 inches in length. But if you have a different age group patient, you are all the time examining with the same cuff. You can fold it for the infants of children of 2 to 5 years, but neonates and infants are very difficult, and you have to have a proper cuff with a proper width. And for the thigh also, if you have to take a pressure in the lower limbs, the proper cuff should be there, and even for the obese patients. If you are using the same one, then you are really taking in an obese adult a pressure which is much higher than what it should be. Technique. Very simple to say, but most of the time not followed. The patient should be really relaxed and quiet. It can be supine or sitting position. Infant of a 6 weeks when awake and crying, the BP comes high by 7 millimeters rather than when asleep. So you can imagine you are going to put the child into a category of hypertension. Children are really more at ease in the sitting position than in the supine. Right arm should be fully exposed, not on the clothes, on the table, and it should be lying at the level of the heart. A sphygmomanometer to be placed at the level of observer's eye. Inflate the cuff to 20 or 30 millimeter above the point at which the radial pulse disappears, and deflate, not very fast, at the rate of 2 to 3 millimeter mercury per second. Systolic pressure is the first sound which appears, and diastolic at the K4, that is at the point of muffling. Now, K5, that is the point of disappearance, is recommended by the International Committee, and this corresponds in the normal individuals with the diastolic pressure if we record it intraarterially. But if you have a patient of aortic regurgitation, then the diastolic pressure is going to correspond to K4, that is the point of muffling. Now, going on to the jugular venous pulse. Venous pulsations are better seen than they are felt, and they can be distinguished from the arterial pulse at times by obliterating at the root of the neck. Actually there are 3 rises and 3 troughs, but we see in the neck, when we see the internal jugular vein, we do not see that. We just see the oscillations produced on the skin, and they are mainly the A and the V followed by X dash and the Y. This is what is seen. When we are examining a patient for the jugular venous pressure, most of the time when the patient is lying supine, and the examination for a cardiac patient is done really at a 30-degree angle. And if you can see that the oscillating waves are high up in the neck, you can make it 45, you can make it even 90 degrees. But if you do not see them, then you can lower also, make it more supine, or even raise the leg and try to see. Now, what it helps is that if you see the A wave which is flickering and is much more than the V wave, we think of certain conditions like pulmonary stenosis, pulmonary artery hypertension. The V is high and the Y descent is marked, we think of tricuspid regurgitation. If A and V are equal and X and Y descents are nearly equal and produces a W or a M pattern, we think of constrictive pericarditis. At the same time, when we are examining, we can see in deep inspiration what happens to it. Normally, it becomes less, but if it becomes more or remains the same, a small sign is a feature of constrictive pericarditis. Now, examination of the chest, and that is the inspection. We, I think, nowadays never go to the foot end of the patient. Examination cannot be done from the right side. One has to go really to the foot end and examine the patient and look at the chest. You have to see the respiration, the type of respiration, frequency, regularity, and the depth. Look if there is spider nevi or any dilated veins on the chest wall. And looking at that, I'll tell you here that if the flow is caudal, it's a superior vena cava obstruction. If it is cranial, it is inferior vena cava obstruction. Thorax, you have to see whether it's a muscular thorax with less developed lower limbs, which may mean coarctation of aorta. Sometimes it's a shield chest, like a Turner syndrome. Pectus carinatum or pectus excavatum. Carinatum is a beak chest and excavatum is a depression, which is seen in Marfan syndrome. One has to see if there is a straight back syndrome. Many times there is a murmur in the heart and we do not know whether it is because of atrial septal defect or it is because of the straight back syndrome. So one has to really look that there is loss of kyphosis of the thoracic vertebra. Then coming on to the pulsations in the precordial area, and the various areas are to be seen. That's the cardiac apex, nearly the fifth space or outward. One has to see if you can see the cardiac pulsations which are heaving or not. Or at times, apart from that apex, you can see other pulsations which come after that, which can be a paradoxical ones because of the aneurysms. Then you have to see the parasternal region, pulmonary area, aortic area, suprasternal notch and epigastrium. Please do not miss any of these areas when you are inspecting. Then shaking of the pericardium, the whole precordium may be shaking. This happens in a large left to right shunt or sometimes a very severe regurgitation, sometimes in the case of complete heart block and IHSS too. Now all those findings which you have seen on the chest on inspection are to be confirmed by palpation, and this is the way that the 3 fingers are used and the metacarpal bones are used, and one is seeing what all is to be seen. Now, firstly, if we go on to the cardiac apex, what is a cardiac impulse? Cardiac beat or the cardiac apex is the lowest and the outermost part of the cardiac impulse. But at times it is not the point of maximal impulse. So that's how you should not be very dogmatic to say that this is the point of maximal impulse, because maximal impulse at times may be in the pulmonary area. So this normally cardiac impulse is in the 5th left intercostal space and it is 9 centimeters from the mid-sternal line and at the mid-clavicular line. Nipple may or may not be a reference because it is variable. Now once you palpate, then you have to know whether it's normal or a LV type or a RV type of apex. Normal impulse really is uplifting the finger but it's short duration. Whereas when the lift is more and the area occupied is about 3 centimeters and the lift is sustained, then it is called heaving and sustained apex beat. But if it is lifting the finger, but at the same time the fall is rapid, it is called hyperdynamic LV type of apex. The sustained heave means a pressure overload and hyperdynamic means a volume overload. To give you an example, heaving apex LV type is an aortic stenosis, and hyperdynamic LV apex typical example is aortic regurgitation. RV hypertrophy doesn't lift the finger, but it gives you a tap, and the tap is very characteristic in mitral stenosis. When you are examining the apex, at the same time you can keep the other hand, left hand palm on the parasternal region, and at the same time feel if that retracts or it doesn't retract. When you are feeling the apex, this area should retract normally. After the cardiac apex, we have to see about the parasternal lift, and this parasternal lift is also can be heaving or it can be a hyperdynamic. Then in the pulmonary area, feel for the pulsations. If you can feel the pulmonary artery pulsation as a outward systolic motion of your hand, or sometimes the second sound will be palpable as in pulmonary artery hypertension. Similarly, in aortic area, suprasternal notch. Never miss it, because you can feel a dilated aorta, or which can be also a feature in a case of aortic aneurysm. Epigastrium. We get patients who have cor pulmonale, who have emphysema. You are not able to feel the right ventricular impulse in them. This you can feel with the finger of your right hand in the epigastrium. It's not only characteristic for that, but in cases who are cyanotic, small children, cyanotic congenital heart disease, where you have tetralogy, then you have to distinguish whether it's a tricuspid atresia or not. If you find absent pulsations in the epigastrium of right ventricle, this suggests that it is a tricuspid atresia and not a tetralogy, because the RV is absent in that. Now, the last is the abdomino-jugular reflex, and this one does when we think that the patient has TS or TR and try to look at the jugular veins at the same time. What we are seeing on palpation are the lifts, thrills, and the apex beat, which was heaving or not, or RV type or a LV type of it. Now, thrills, how to know whether the thrill is systolic or diastolic? You have to feel the carotid pulse at the same time. The one which follows it is a systolic one. Now, coming on to percussion, which is not very important except for pericardial effusion, and hardly a normal examination or routine examination really carries any meaning for that. Going on to auscultation, and that is the heart sounds. There are 4 heart sounds which are there: S1, S2, S3 and S4. Taking them one by one. S1. There are really 4 components of first heart sound. 2 of them are really high frequency, and they are the ones which are heard. And the first one is at the mitral valve, and the second one is at the tricuspid valve. This coincides with the closure of the atrioventricular valves. Now, these 2 components are separated by about 20 milliseconds, which is really not appreciated by the normal ears, and so we hear only one sound. But sometimes there can be a wide splitting, and that occurs in right bundle branch block, left ventricular ectopic beats, left-sided WPW pathway, epicardial pacing or Epstein anomaly is a typical example of it. Then first heart sound can be loud, and the typical example we all know is mitral stenosis, left atrial myxoma, mitral valve prolapse, and short PR interval, tachycardia, hyperthyroidism, and even in small normal children. First sound is soft in patients with chronic airway disease, obesity, pericardial effusion, prolonged PR interval, left bundle branch block, calcified and fibrotic mitral valve, aortic regurgitation, LV dysfunction. Variable S1. When there is atrial fibrillation, the S1 is variable. if you have a long RR interval, after that you hear a loud sound and complete heart block. Second heart sound is more interesting and has more features than the first heart sound, and this is produced at the time when the aortic and the pulmonary valve close. First is the aortic component, this is followed by the pulmonary component. Normally in adults, aortic component is louder than the pulmonary component, and in inspiration you have two components, whereas in expiration there is only one component. Now, to give you examples that these are movable, that see a case of atrial septal defect where we all know there is a wide splitting of the second heart sound and it is fixed. There is delay in the P2 component, and in inspiration and expiration they remain at the same point. In pulmonary stenosis, you see that it is a wide split, but P2 is weak. In mitral regurgitation, it is wide, but the A2 component is earlier. And in aortic stenosis, when A2 component is delayed, then there is only one sound which is heard at times, or this is called a reverse split or a paradoxical splitting which is seen. MR is the same as VST most of the time. Now, the causes of wide split second sound can be RBB, LV ectopic beats, WPW, and LV pacing. Mechanical delay can be in PS, large pulmonary embolism, and commonest example is atrial septal defect and loud and in MR and VST. Reverse splitting, the common or paradoxical splitting, common examples are LVB, aortic stenosis, LV dysfunction, AR, PDA, coronary artery disease. Apart from that, we sometimes find additional sounds, and these sounds can be the presystolic gallop, or it can be following first sound, that is ejection click, can be pulmonary or aortic, and the split second sound I explained you, and in diastole about 60 to 120 milliseconds after the A2 you can hear a opening snap, and sometimes a mid-systolic click in a case of valve prolapse. Lastly, about the murmurs, and one has to see the characteristics, location, timing, shape, pitch, radiation, and change with the various maneuvers. Intensity, grade 1 to 6 you all know, but when you are describing, please do describe whether it's grade 1 by 6 or 2 by 6 or not. Now, the various types of murmurs which we know, between the first and the second sound is a systole, so the murmur which comes between them is a systolic murmur, and the murmur which comes between the second and the first is a diastolic murmur. The various varieties are pansystolic, that it lasts throughout the systole, it is MR, TR or VST. If it is ejection systolic, that is it occurs after the first heart sound, peaks in the mid-systole or late systole of aortic stenosis. But mind you, aortic stenosis and the pulmonary stenosis differ. Aortic stenosis murmur ends before the A2, whereas ejection systolic murmur of pulmonary stenosis will cross the A2 if it is severe, and it ends before P2. Early diastolic murmur, that is a decrescendo murmur, is characteristic of pulmonary regurgitation and aortic regurgitation. Mid-diastolic murmur of mitral stenosis. A short diastolic murmur after the third heart sound can be a flow murmur in MR or VST, and continuous murmur which passes uninterrupted through the second sound is a patent ductus arteriosus. These murmurs vary with inspiration, expiration, various maneuvers like isometric exercise and Valsalva. Just to give you the example, and this is the last one, that if you see the control of mitral regurgitation and you do the Valsalva maneuver, this is being done against a manometer at a 40 millimeter mercury for 10 seconds, or it can be expiration against a closed glottis. This murmur of mitral regurgitation decreases, whereas aortic stenosis murmur also decreases. IHSS murmur on the other hand will increase, and a late systolic murmur of a mitral valve prolapse with a click becomes earlier and becomes longer. So these are the various methods of examination. Regarding the JVP, there are two questions. One is that how do we know that it's A or a V wave? If you cannot make out, most of the time the A is a flicker, sharp rising, and V is undulating. But if you cannot make out, then keep your left hand thumb on the right carotid and try to feel the carotid pulse. The wave which comes before the carotid pulse which you are feeling is the A wave, and the one which comes after is the V wave. The second question which is there on JVP is what is X dash and what is H wave. I think the nomenclature which I showed was slightly different. The A is followed by X, the C is followed by a trough X dash, and that is X dash. And what is a H wave? At times in pericardial effusion or massive pericardial effusion or tamponades, we do not have Y descent, and instead of a sharp Y descent from the V wave, there is another wave which is a positive wave, and that is called H wave. It's hardly recognizable in the clinical examination, but it can be better recorded and better seen in the RE tracing. The next question is, how do we differentiate between hollow systolic murmur and pansystolic murmur? They are actually different things. Pan means the whole of systole, right? Starting from S1 up to S2. Example will be MR and TR. But hollow systolic murmur is mainly in MR, which means that it is heard with the same loudness throughout the systole. Whereas in TR, most of the time, what we hear is that the first component out of the three is loud, the second one is less loud, and the third one is again less loud. That is, it is not heard with the same frequency throughout. How do we feel for water hammer pulse is another one. It's a thing which can be demonstrated at the bedside, that the right wrist of the patient who is lying supine with the arm lying on the side, you hold it with your right hand and lift it above the head. When it comes in alignment, then at the pulse which you are not feeling or mildly feeling, they strikes on your fingers as a water hammer. That's how it is described, as a water hammer pulse with a great thump. The last is, since we do not have different cuffs for all age groups, is there any formula to derive? Really, there is no such formula. For neonates, how can you have formula with an adult cuff? There is no such formula available. The only thing is that what you record when the person is obese with a smaller cuff, the blood pressure which you are recording is higher than what is normal. And if you in a small child record with a bigger cuff, then you are recording a low reading, which may be 5 millimeter, which may be anything, but there is no such formula by which we can derive. In fact, each one of us should have at least a neonate and a child cuff or an adult cuff available in our labs or in our clinical examination room.
Thank you very much, Dr. Ramesh Arora. I think viewers must have been benefited the way she has gone about the histories, the steps in the history and physical examination. And as the postgraduate students of belonging to the medical sciences, you will appreciate that the nothing is like and more important than taking accurate history and physical examination, which is so very essential in a simple, even in a simple case of pyrexia of unknown origin, leave aside the cardiac problem. So I think as students and learners of cardiology, we have to attach utmost importance to these steps in history and physical examination, the way Dr. Ramesh has explained everything about after the history, the physical examination, how you should do the inspection, that not from the right hand side, go to the foot end and see and look at the chest, the various characteristics that she has mentioned, and then how to do the palpation, and the palpation how to feel for the cardiac apex, where it is located, which intercostal space, what is heaving, what is parasternal heave, suprasternal notch, what you have to feel in all these places, epigastric palpation. You see, these are the things, if you do very carefully, you will lead to a tentative diagnosis which can be confirmed by some laboratory investigations and radiological examinations. So I'm very grateful to you, Dr. Saab, and thank you very much for listening. Thank you.